Assalamualaikum and good day. I am Dr. Mardiana and I will be delivering the second part of the lecture on diseases of the male genitalia. So let's recap our learning objectives for these two lectures. Is that at the end of these two lectures, or these two parts of the lecture, you will be able to describe risk factors, pathogenesis, morphology, and clinical effects and complications of the four entities listed here. And in this particular part of the lecture, we will focus on testicular neoplasms and carcinoma of the penis. And skill-wise, you will be able to identify the morphology of testicular neoplasms for this part 2 of the lecture. Okay, so that's the content, and that's the learning objectives for part 2 of the lecture. So we will start with discussing testicular neoplasms. However, the discussion won't be complete without explaining a little bit on cryptorchidism. Okay, so what is cryptorchidism? Cryptorchidism, or undescended testis, basically refers to failure of testicular descent into scrotum, and it is detected after 1 year of age, affects roughly about 1% of male population. Most cases are unilateral, however about 25% of cases can be bilateral, affecting both the left and the right testes. So why did I say we have to touch on this before we move on to testicular neoplasms? The fact is really because it has an association, it is a known association to developing testicular cancers. In fact, it has a 3 to 5-fold of increased risk for testicular cancer. Okay, and it's not confined to cancer only in the undescended testes, but also the risk applies to the contralateral testes as well. So apart from the risk of cancer development, it also will result in testicular atrophy and infertility. Okay, so straight to business, testicular tumors. Testicular tumors, there are various types. Okay, so we can roughly divide them into germ cell tumors, sex cord stromal tumors, and also other types of tumors that can affect the testes, such as lymphoma, sarcoma, etc. In this particular lecture, I will only focus on germ cell tumors of the testes. Germ cell tumors of the testes can be further divided into two, which is seminoma, as well as another group of tumors called non-seminomatous germ cell tumors. So we will go through them in a moment. Examples of sex cord stromal tumors include Sertoli-Leydig tumors, but we will not be discussing these entities in this particular lecture. Another note to mention on germ cell tumors, okay, in post-pubertal males, about 95% of testicular tumors arise from the germ cells, and they are almost all malignant. Okay, and the precursor for germ cell tumors is called germ cell neoplasia in situ. So let's move on to the risk factors, pathogenesis, and the precursor lesion of testicular germ cell tumors. The cause and pathogenesis of testicular tumors are actually not well understood, but there are some risk factors for its development. As I've mentioned earlier about cryptorchidism, okay, cryptorchidism is one of the most important risk factors. Okay, again, the risk applies to the undescended testes and also in the contralateral testes, right? So that's actually a very important risk factor. There are other associations, okay, such as with androgen insensitivity syndrome, gonadal dysgenesis. There's also a risk associated with a positive family history. History of cancer in one testis will definitely increase the risk of developing cancer in the other testes. One thing that is constant in pretty much all germ cell tumors is that they all have extra copies of the short arm of chromosome 12, right? In terms of the precursor lesion, I would like to mention here germ cell neoplasia in situ. This is the precursor, and it is identified in the vicinity of germ cell tumors in about 90% of cases. It is often seen in conditions that are associated with increased risk of cancer. So for example, if someone has cryptorchidism or undescended testes, if the testis is removed a little bit later, then you may be able to see the presence of germ cell neoplasia in situ there as well. So whenever you see that, then you know there is a risk of developing testicular tumors, because without any intervention, approximately 50% of these cases or testes that contain germ cell neoplasia in situ will progress to invasive carcinoma. So this table highlights the various types of germ cell tumors that can occur within the testes. So we mentioned earlier that the germ cell tumors can be divided into seminoma and non-seminomatous germ cell tumors. The non-seminomatous germ cell tumors is actually a group of tumors within which you may have embryonal carcinoma, yolk sac tumor, choriocarcinoma, or teratoma. Of all these germ cell tumors, the most common type is actually seminoma. It has a peak age of around 30 to 50, so third to fifth decade. It has the best prognosis of all. So it's often confined to the testis for a long time before it disseminates elsewhere. It is also radiosensitive, so that is one option of treatment, and it is treated by orchidectomy. For the rest of the germ cell tumors, it is worth mentioning that germ cell tumors tend to occur as mixed type or mixed germ cell tumors. So while they can occur as pure form, when I say pure form, it means that the tumor only contains one component. So the tumor can be a pure seminoma, so the entire tumor is composed of seminoma, or it can be a mixed type. So it can be seminoma plus a component of embryonal, or embryonal plus a component of yolk sac, or embryonal plus component of yolk sac, chorioteratoma. Okay, so it's any combination of that is called a mixed germ cell tumor. So often germ cell tumors occur as mixed forms rather than pure form. But the individual component does have a different prognosis and behavior, if you like. So if we look at embryonal, for example, embryonal tends to be quite aggressive. So they can have retroperitoneal lymph nodes or distant metastases even at diagnosis. And I'm moving down here to choriocarcinoma. So choriocarcinoma again is also another differentiation or another type of tumor which is rather aggressive and has the worst prognosis compared to other GCTs. I'm reserving yolk sac tumor and teratoma towards the end, because you can see that for these two tumors, when they occur in pure forms, okay, they have different prognosis in children versus adults. Okay, so for both tumors, if they occur in children, the prognosis is excellent. Okay, yolk sac tumor, for example, excellent prognosis in children, but in adults, the prognosis will depend on other components that are present. So for example, if the yolk sac tumor occurs in combination with choriocarcinoma, then the prognosis is dictated by the choriocarcinomatous component. So the other one is teratoma. In teratoma, it's also the same. The prognosis differs, or the behavior differs, depending on whether it occurs in children or in adults. Teratoma in children is essentially a benign tumor. They behave in a benign manner and they have excellent prognosis. But teratoma in adults is essentially a malignant tumor. So another thing to mention, if we look at the column peak age, you can see that in adulthood or post-pubertal germ cell tumors, the embryonal yolk sac, chorio, and teratoma, they occur most commonly at a slightly younger age compared to seminoma. So they occur probably around the second and the third decade. And then if you look at the third column here, which is tumor markers, so again, this is another important point that I want to highlight. There are two tumor markers that are particularly useful when you are dealing with germ cell tumors. One is alpha-fetoprotein, so serum alpha-fetoprotein, which tends to be elevated in yolk sac tumor, and the other one is beta human chorionic gonadotrophin, or beta HCG, which is often elevated, or rather it's elevated in 100% of choriocarcinoma cases. You can see here with a bit of asterisk, HCG can be mildly elevated in seminoma, and this is due to the presence of occasional syncytial trophoblasts in there, but the elevation is mild and not marked like you see in choriocarcinoma. Okay, so just a note down there to show that GCTs are often mixed, so the tumor can be something like a pure seminoma, it can be a non-seminomatous germ cell tumor without seminoma, or it can be seminoma plus non-seminomatous germ cell tumor with any sort of combination at all. Okay, so we'll just briefly go through the individual germ cell tumor types and some salient features regarding them. So we start with seminoma. So in a pure form, a pure seminoma, it tends to produce only a homogeneous cream white tumor, which is often quite well circumscribed. It often lacks any necrosis or hemorrhage, so it really forms a cream and tan kind of firm mass. Doesn't look particularly scary, but of course it is a malignant tumor. So it can occupy only part of the testis like this, or it can grow to quite a significant proportion and replaces almost the entire testicular tissue. Histologically, the tumor cells are uniform. They have prominent nucleoli and they have this clear cytoplasm. Another important characteristic is that they often have this fibrous septa separating the lobules of tumor cells, and these fibrous septa are infiltrated by lymphocytes, which is quite characteristic. In terms of embryonal carcinoma, okay, embryonal carcinoma tends to be a bit more variable. So they can form large masses. They're often hemorrhagic and necrotic. So you can see that it is a bit more heterogeneous. And histologically, they're also quite variable in terms of patterns, but they display extensive pleomorphism. Okay, so poorly demarcated mass and tend to be heterogeneous. Yolk sac tumor, okay, it's a bit of text there because again I highlighted earlier. It can also occur in pure form in childhood. In fact, it is the most common testicular neoplasm in pediatric population, but they have excellent prognosis. And in adults, they tend to be mixed. In terms of morphology, they can have hemorrhage or necrosis, therefore it can be quite heterogeneous. And histologically, again, quite heterogeneous with variable growth patterns. But the characteristic feature that can be present is what we call the Schiller-Duval body. So the morphology of the tumor or the architecture of the tumor resembles primitive glomerular structures. They can also have hyaline globules. Teratoma, again, also I mentioned earlier, there is a distinct differences between teratoma occurring in pre-pubertal or childhood versus adults. Okay, so in adults, it's uncommon to be pure teratoma. Usually it's mixed. You can have immature tissue present, and the behavior is malignant. They produce multiple patterns of differentiation, which correspond to the ectoderm, mesoderm, and endoderm origins. So what we see is essentially various types of tissue within the tumor. So for example, you can see squamous epithelium with keratinization resembling skin. You can see cartilage. You can see bowel mucosa, for example, within the tumor. So as a result, the gross appearance also tends to be heterogeneous because of this variable differentiation that is present. And then in terms of choriocarcinoma will present as a hemorrhagic nodule or mass, and histologically the main or salient feature is the presence of atypical cytotrophoblast, okay, which is here, and also syncytial trophoblast, which is the largest cells here, which show these aggregates of nuclei within the tumor. Before we move on to clinical manifestations, I just want to highlight that these germ cell tumors within the testes also have their counterparts within the ovaries. So when you are learning about the ovarian tumors, you will find that the germ cell tumors of the ovary will have a similar morphology in terms of growth and also its microscopy. So moving on to clinical manifestations, often patients present with painless unilateral testicular enlargement. This can be quite bulky. Occasionally, patients can present with secondary hydrocele, so fluid collects within the scrotal sac as a result of the presence of tumor. Rare presentations include gynecomastia due to elevated HCG or infertility if you have destruction of the testicular parenchyma. However, these are uncommon. Patients may also present with symptoms from metastases. For example, if there is metastasis to the lung, then patients can have hemoptysis. If there is metastasis to the bone, then the patient can have bone pain, etc. In terms of clinical aspects of the tumor, the presence of any solid testicular mass is considered to be neoplastic until proven otherwise. While it is outside the scope of this lecture, it's interesting to note that in terms of workup of testicular tumors, we don't often biopsy testicular masses for fear of seeding of the tumor into the scrotal skin. So the presence of any testicular masses which are suspicious for malignancy often results in resection of the testes. So clinical features and tumor spread, similar to any cancer elsewhere, modes of spread can be direct to adjacent structures, in this case, for example, the epididymis. Metastasis can occur via lymphatic or hematogenous routes. So in terms of lymphatic routes, these often go to para-aortic lymph nodes, mediastinal and supraclavicular lymph nodes, and seminoma especially tend to metastasize via the lymphatic route. Hematogenous routes will result in metastatic nodules or metastatic foci in the lungs, liver, brain, bones, etc. So we have mentioned about the tumor markers. So another one that I haven't mentioned is LDH, which is lactate dehydrogenase. LDH is not differentiation specific. So we mentioned AFP is rather specific for yolk sac tumor and HCG is rather specific for choriocarcinoma, but LDH is not. LDH simply relates to the tumor burden. So the more tumor you have in the body, then the higher the LDH will be. The rest of the management is beyond the scope of this lecture. Okay, so that's on testicular tumors. So quick recap. Someone may have risk factors such as cryptorchidism, family history, etc., which lead to development of testicular tumors. Testicular tumors can be either seminoma or non-seminomatous, and within the non-seminomatous germ cell tumor, you have embryonal, choriocarcinoma, teratoma, and yolk sac. But it is worth remembering that these tumors in adults tend to be mixed rather than pure. The clinical manifestation of testicular tumors we have discussed, which can be in the form of unilateral swelling or may relate to distant metastases to various organs. We also mentioned the tumor markers which are associated with specific type of germ cell tumors such as beta HCG for choriocarcinoma and AFP for yolk sac tumor. And we have also discussed earlier about their behavior, which in certain types of tumors such as teratoma as well as yolk sac tumor can have different prognosis in children versus adulthood. So just briefly on penile squamous dysplasia and squamous cell carcinoma and dysplasia, okay, will be discussed together because, as you know, dysplasia is the precursor for squamous cell carcinoma. The risk factors for developing squamous cell carcinoma of the penis is number one, if someone is not circumcised, if there is poor hygiene, which results in collection of smegma, and that can be the nidus for the development of dysplasia and cancer. And there is also a very strong association with infection by high-risk human papillomavirus, HPV, especially serotype 16 and 18. So this will lead to the presence of dysplasia, which can progress to carcinoma in situ, in which the dysplasia involves the full thickness of the squamous epithelium. However, the basement membrane remains intact. Another term that is often used for carcinoma in situ in the penis is Bowen disease. Subsequently, if the basement membrane is breached, then the patient will develop invasive squamous cell carcinoma. The location of squamous cell carcinoma is often on the glands. They can form indurated nodule or plaque, or they can form a large mass. Okay, often they are ulcerated, like you can see in this image here. Histologically, as with squamous cell carcinoma elsewhere, you will find the presence of atypical squamous cells, islands of atypical squamous cells like shown here, with evidence of keratinization and maybe intercellular bridges as well on high power magnification. In general, invasive squamous cell carcinoma tend to be confined to the skin for quite some time initially, and then they invade the deeper tissue, after which they often display rapid growth. Metastases will occur to the femoral and inguinal lymph nodes. One thing worth mentioning, again, this is generally an uncommon tumor, but they occur more in developing countries compared to developed countries. And the typical age group for the development of squamous cell carcinoma of the penis is between 40 to 70 years of age. So that marks the end of part 2 and the end of the lecture on diseases of the male genitalia. So again, the references that I use are as listed here. I hope you find the lecture content clear, and all the best.